I have a difficult topic, I think, because we're going to talk about genetics. And so my goal is to try to talk a little bit about what I do in the clinic, what is my role with patients with vascular anomalies, and how do we try to help, and then maybe get input from you guys. What is working, what's not working, what can we do differently? And we'll be here through the weekend, so we're available for other, talking outside of this podium. And so I don't have any conflicts for today. And so the first thing I thought was just talking about medical genetics in general. And so I am a physician who trained in pediatrics, but then trained in genetics and then did further training within genetics. And as such, we train in medical genetics across the lifespan of individuals, and that's what's allowed me to see patients who are teenagers and adults with this type of conditions. If we look at it in the broad, scene, there's around 1 in 10 Americans walking around with a rare disease. It's estimated up to 10% of the general population will be diagnosed with a rare condition. And the disorders that we're talking about here would be recognized as rare conditions. And so I guess you guys are part of the family of things that I see in my clinic. When I see someone, I can see them in the hospital, inpatient, or I may be seeing them in the outpatient clinic, in the external clinic. And when you spend time with us in the clinic, you spend like an hour at least with us, sometimes more. We try to gather a lot of information. So we spend time, even if you're an adult, trying to figure out how was your birth history and how you developed and how you grew. Taking a family tree that we'll draw and show you guys. We'll do a full physical examination. It's usually a head-to-toe examination. And then one of our major roles is ordering, but then interpreting genetic testing results. And so with that knowledge, the hope is how do we better manage a condition that may be in front of us? And so with the purpose of it, it's usually to clarify why some of the symptoms are happening. Now, mind you, we can't always do that. We can't always give that final diagnosis, but we will try if we can. Why do we try to do that, right? And so our goal is that if we, and not label is not the right word, but if we can name something, then all the accrued information from the medical literature is suddenly at my fingertips. Do I know everything? No. Would I be able to tell you specifically when symptoms are going to develop? No. But can I tell you some of the symptoms that people may be at risk for and offer surveillance for them? Then the answer would be yes. Would then you know to search for support groups like this one? Then the answer would also be yes. Although we understand that some diagnoses will also be clinical. And then we do try to avoid unnecessary tests if we can, and refine treatment options or give access to medical trials if they're available. So when you sit with us, the nice thing is, at least in our clinic, I work with a wonderful genetic counselor, Janet Dimonda, who's not here today, but maybe some of you guys will get to meet. And we sit down with you guys and we'll go through it, and we offer the support groups and we talk about what options we have. And so I know most of you already know about all the changes in terminology, and this is just a very simple, way of showing it. But when I'm looking at the classification of vascular anomalies, of the bigger terminology, and I'm thinking about the big two groups, what we call the vascular tumors now, where the hemangiomas would be, you'll hear that suffix oma at the end of those tumors, because the way that they grow is a little different. So if we were looking under the microscope, we would see more cells proliferating, growing usually more rapidly. But also that's why I get the medical history up front, because when things begin, how they evolve may give me a little clarification. Are you in those group or are you in the other? The people I see the most are the other side, which are the vascular malformations. And so how they differ is in the malformations. Usually there's a true developmental difference on how those blood vessels or lymphatic vessels actually formed, usually in utero, so when we're in our mom or tummies. And they're usually congenital, so they're usually present at birth. The symptoms may not be evident always at birth, but usually we expect those to have happened very, very early on in embryonic development, so when the baby's forming. And depending on which blood vessel is mostly involved, then we give it names. And so that helps us out, also try to tease things out and say, what can I offer in this scenario or this other scenario? And so in the bigger names that you'll hear up top the capillary malformations, which are these smaller blood vessels over here, the bridge between the arteries and the veins. Because imagine you're pumping blood out from the heart at really high speed, and you need to diffuse it before it gets to your lower flow on the vein side. You can have differences in the veins per se. You can have these differences in the arteries or on the lymphatic channels that have their own system and are trying to move fluid, which is called lymph, around, but also have some important functions with the immune system as well. Now, from the genetics perspective, what we've started knowing in the last few years, if you have one of these isolated differences somewhere in your body with these blood vessels, now we found genes that may not be working well and cause those things to happen. And you'll see that there's genes for each of those specific conditions here, but there's genes like the ones that I think you've heard of a lot, like PIK3CA, that may cause different types of these malformations. So the same gene, if I'm looking at someone physically, may be causing a lymphatic difference or a venous difference, and I may not be able to tell just from my clinical exam alone, and that's where sometimes the genetic testing comes into play. If you guys don't know what genes are, we talk about genes like stretches of DNA, and our genes are organized in letters and orders of letters. And we expect them to have a specific order for each of those genes. And each of the genes would be the instruction to make what we call a protein in our body. It's not protein like the ones that we eat from food. It's proteins that make structures in the cells or send signals in our cells. And so what we know now about all of these genes, and I'll show them here, do not try to learn this. The arrows in yellow are showing you all the genes that I just showed you. They are all related to each other. That's the takeaway. And so that's probably why when some of these cells are not working well, they all cause different, symptoms, but are related to blood vessels too. And so what we know so far is that if we have cells, and we have trillions of cells in our bodies, all of them have a little membrane so things don't get in and out of the cells. So it's like a little cover. There's these little sensors up top telling our body what the cells are sensing outside of it. And so usually you activate those genes when there's certain things telling it to be active and turn on. In patients with these conditions, what happens is these genes remain too active for long periods of time. And so that also tells me that this process that is happening in people who have these vascular differences is not static. It's probably dynamic. It's continuing to change a long time because these genes don't get turned off appropriately and they stay on. And where they all converge is telling the body to make new cells, to make more cells, to allow those cells to survive, and for a process called angiogenesis. And angiogenesis means making blood vessels from existing blood vessels. So it's telling our bodies to keep making them. And so that's why we believe these processes are happening. Now, because we knew some of these genes are also associated with cancers, that doesn't mean our patients are going to have cancer, but we can borrow a lot of information from other conditions and then use it for the purpose of treating and diagnosing these conditions, and that's a lot of what's been going on. And so what we've learned is, okay, now we are going to have new ways to help and try to diagnose, but also treat these conditions based on that knowledge. And so now I wanted us to look at one of those genes. I think you guys already have heard about it. It's called PIK3CA. And so PIK3CA is right here. And the way I think about it is like almost like a relay race. It's staying active when it's not supposed to, but then it's activating the next thing that is leading to that extra cell growth and cell proliferation and making of the new blood vessels. And so it is part of this signal within our cells. And when there are variants, DNA changes, then there can be those misspellings that lead to the superactivation of the pathways. We in genetics don't use the word mutation anymore. We just like to make things hard, and now we say pathogenic variant. It's just make it harder and longer. But the distinction there is when we use a word like pathogenic is we are trying to mean in the medical community, this variant, this DNA change, this misspelling can cause symptoms in a person. Because we all are going to have variants in our genes. None of our DNAs, if we look at them, are going to be spelled exactly the same way. And then the other thing that is important to know about this gene and how it relates to these conditions is when these variants occur, most of the time, they're happening after a baby is made. And so if you think about it, our fathers give half of the genetic information to make us. Our moms give the other half, or the egg or the sperm. When they come together, they have the full complement to make an individual. But one single cell is not enough to make a full-grown person. The DNA has to then be copied and passed on to each next cell. Every time we copy, there can be misspellings introduced. We think this happened at random, and if one of those happens in one of those genes, only the daughter cells of that specific cell will have the difference in the DNA. And so how that presents, if it happens in one of these pathogenic variants in one of these genes that can cause the symptoms, is that we'll only see symptoms in specific areas of the body. Another way of looking at it is like this. The baby's forming. There may be different times in which these differences are happening, but there can also be happening in different body parts and leading to differences in different tissues and organs. Sometimes more than one, sometimes just one, sometimes one area, sometimes multiple areas. And it's then very hard for us to predict how it's going to happen and what symptoms specifically are going to happen. So that's why when we see you guys in clinic, none of you guys are exactly like each other. Everyone has its own complement. And so we have to maybe target to what's best for the person up front. And so this type of differences in genetics that affect only different body parts, we call somatic mosaicism. So you may hear that when you meet people. Now, with this big umbrella term that has come up, right, that we're calling PIK3CA related overgrowth spectrum, or PROS, what is required to make a diagnosis as we know it right now? I think these things are going to evolve over time. Usually finding that a variant in one of those genes, so a DNA change, a pathogenic variant, which is very hard to do, as you all here probably know. We also expect that you have very early onset of disease or congenital, so right after birth or within usually the first year of life. And then that distribution that is not usually all over the body. The other things that we expect is that some of these body parts are also different. And so the body parts that are most commonly different with this type of conditions are the brain, the skin, the blood vessels, and then also the bone, the muscles, and the adipose, which is the fatty tissue that we all have. Some people only have one of those areas that is different. So if it only affects the skin, but has a mosaic pattern, it was present at birth, and you find a variant, we call that isolated right now. I also think this terminology will evolve with time. And then if two or more body parts are affected, sometimes we'll call it syndromic. It's a way sometimes for us to differentiate it a little and to try to target surveillance if there's more than one body part that is different. But it may not be great for everyone that comes through our door. And I think we acknowledge that as physicians. Now, within the group of PIK3CA-related disorders, that PROS, some people have started putting Klippel-Trenaunay syndrome within the group. And the reason for that is because more recently, people who had symptoms of Klippel-Trenaunay who have had some genetic testing may have tested positive for PIK3CA. But keep in mind, not everyone may be tested for many different reasons, and or there can be conditions that can look like it as well. So this is how the literature shows it right now. That does not, I think, negate that people have KT as a clinical diagnosis. So I do want to try to make a little bit of that differentiation. And whenever we don't see some of these symptoms that are here that affect several body parts, like for instance, this one here usually affects the brain. This one here usually affects the middle part of the body with some overgrowth of fat and some involvement of our spinal bones. When it's not like that, sometimes we'll see, okay, they're isolated vascular malformations. So there may be people who only have a lymphatic difference or a venous difference without some of the other symptoms. And some people will have only lesions in the brain or only lesions in the skin. And so it's a lot. This is not meant for you guys to know all of it, just so that you can get an idea of how complex it actually is and how the terminology keeps moving. It's a moving target for us as well. But if I start looking at some of the literature, it is around 2012, 2015 when people start getting these genetic tests. And around this time is when they start saying, well, maybe that's why we think Klippel-Trenaunay belongs to this group of conditions. But if we take KT separately as its own entity, what would be the symptoms that are the core symptoms that I'm usually looking for a clinical diagnosis if I'm seeing someone in my clinic? So there's 3 core symptoms. We call it a triad. One is the capillary malformation, which a lot of us will call a port wine stain. The second one is vascular malformations that are low flow, so usually venous, lymphatic combined, or the varicose veins that we can see. And then the third one is usually an overgrowth, which can include the bone or the skin or the adipose tissue. 67% of people who have a clinical diagnosis of KT have the 3 of them, and around 37% have 2 of those. For me to make a diagnosis in the clinic, I only need 2 of those. And so a lot of times if I can't do testing, I may be saying, hey, you have the criteria for this specific diagnosis. And so if we now put it together with the required features of the other conditions, I would say most people with KT actually do have an early onset or congenital manifestations and a mosaic pattern of their overgrowth. What they may be lacking would be the presence of variants in the specific gene. But there's other things that may look like it too. And so if this is how we may see KT and we think maybe it is related to PIK3CA gene, there's other of the PROS conditions, such as this one here, that may have some symptoms that may also look similar. And so they can also have capillary or capillary venous lymphatic malformations. They can have overgrowth. They can have differences in the fatty tissue and some skeletal differences as well. If I think of, okay, I need to one of the low flow lesions and some of the capillary to make a diagnosis, they would be within the KT if we think about it that way. And this patient over here has a different gene that was found on genetic testing, but also had a capillary malformation and some overgrowth with other types of vascular malformation. So there is a big overlap. And this is why sometimes we do try to get genetic testing to be able to better inform people about their diagnosis, because management could also change based on those results. Over here you have a little bit of a different one, because this one is called Parkes-Weber syndrome. You look at the old literature, we used to say Klippel-Trenaunay-Weber syndrome. It was all kind of clumped together. And these ones can also have the capillary malformation and the overgrowth, but usually with an arteriovenous malformation. What makes it harder is that some of these people with this condition, you can test the blood or the cheek swab and get a positive result, versus some other people who may have conditions such as this one or this one, where we usually need to do a biopsy of some sort to have a positive genetic test. So it is harder to diagnose. And so what do we offer right now genetic testing-wise? So we do it to try to confirm if there's any of those gene variants. But the difficulty is when we see a vascular malformation, it is made of cells that has the change and some cells that don't have the change. If we're looking under the microscope at the blood vessel, we cannot tell which of those cells will have the genetic change and which ones don't. And so that's why it requires very specialized tests for us to be able to find it. And so usually requires specific tissue from the affected area for us to send to the lab to do what we call sequencing. Now, generally speaking, less than 20% of the cells in the affected area will have the genetic changes, which is a very small amount. So we need a special technique that we call deep sequencing to be able to find the genetic results positive. What does that mean? Imagine that I give you a book, and it's 1,000 pages, and there's only one word that is misspelled. And I tell you, get one try to sort through it and find the misspelling. It's very hard. Generally speaking, our genetic tests sort through the information 30 times. For me to find that very small percentage of DNA that would be different, I need to sort through it at least 1,000 times. So it requires very specific techniques that very few labs offer. So access to the tests is harder, and we also recognize that. And so usually what would I offer? So I have the conversation with the families. I say the types of genetic tests that are available. We talk about different types of tests that can be offered from different types of biopsies too. So I do mostly see children, and if children are going to be sedated for, let's say, an MRI or have a sclerotherapy or other procedures done, for me the ideal tissue is the actual cells from the actual vascular difference. And so what the interventional radiologists do is that when they go to do some of the procedures, far away where they're putting some of the agents to shrivel up those blood vessels to make them feel better, they'll take a little sample from it. And that's the sample that is sent to the lab for us to sort through the DNA. Other things that we can consider are a biopsy of the skin overlying an area that is different or that has differences in growth. Overall, we see that the possibilities of having a positive test with those tends to be a little bit lower, but can be offered. And so it could be any of these samples that could be sent. For patients with KTS, we've seen that there's some specific misspellings in the gene that occur more commonly, kind of over and over. We like to call them hotspots. And so, for instance, if this was a sentence, the big rat can run far, and then instead there's this R change for that C, the big cat can run far, we see this misspelling happening many, many times. So sometimes we do know what to target and can make it a little easier for us to find one of these variants. And this is an actual result for one of our patients who had one of those misspellings. The sample type that we used to find this DNA change was a fresh frozen tissue, and it was only present in 6% of the copies of that gene in the sample that was affected, so very, very low.
Good.
And so why do we try to get this test, even if people have a diagnosis? This is a great study published by Dong Lee and Sarah Shepard and many other collaborators. They found that with very specific DNA tests that were sent, of people who had, it's a little different, but it's called complex lymphatic anomalies, 41% received a molecular diagnosis. But for other malformations, including the venous and lymphatic, 72% had a diagnosis. If I see someone with autism in my clinic or other genetic conditions, we find maybe 40% of people have a positive diagnosis for other conditions. So 72 in the genetics world is actually pretty remarkable. And for people with those other genetic conditions, only 5%. If I find a diagnosis, can I change medical management directly? And so the fact that here they were finding that at least, it's not perfect, but at least 63% could start a new medical therapy or improve a therapy to me, it sounds very powerful. And there's definitely more need for new things to come up. In our clinic, what have we seen? This is a hodgepodge of people with many different vascular anomalies and also overgrowth. But, and this number is probably bigger now, but we had around 17 positive results among the people who were tested. What we saw is that if we did that deep sequencing that I was telling you about, reading through many times, and the sample was specifically from the blood vessels, we reached more or less this similar number to this one to give positive results. So we do think that that tends to be superior if, you know, the conditions are set for us to be able to take one of those safely, of course. This is a patient with PROS that I follow. She's not a little baby, and mom gave me consent to show her picture. But we had done a lot of DNA tests. She's older now, so we've also learned and know better now what testing to send. But she had blood work on this arm, taken directly from the arm, including the PIK3CA gene, which had been negative. We had done a skin biopsy, which had been negative, and then a larger tissue specimen when they did a resection from a chest wall lesion was the one who finally found the variant in only 5% of the genes in the area. And this is where the biopsy was taken from. So it was from an affected area. So that shows you how difficult sometimes for us. But that also shows you that some people need multiple biopsies. And that is very hard for the patients too. And so for this young girl, she was able to be started on alpelisib. And of course, she's also had some surgeries, but she had significant reduction. And she's older now, she's the cutest. And so the drug inhibits directly that gene that we've been talking about. So it's a direct inhibitor of that overexpression. Now it's kind of damping it a little bit. It doesn't fully restore it back to normal, but it decreases that signaling and can lead to improvement of pain, fatigue, and sometimes the size of the lesions and the fatty overgrowth. This is just an example of someone who had a growth in this area. When they looked at it under the microscope, there were some vessels that were different. So we were like, well, it could be one of these overgrowth conditions. And so the testing here is a little different because it was a panel that is used for cancer that they could do from the tissue that they had already taken. So this is one of the conversations that people can have with their doctors is, hey, I've already had, a biopsy done so many years ago. I've already had something stored somewhere else. Can we use that? So when we store things for longer periods of time, the DNA can get a little degraded. So sometimes it's not ideal. We will not get enough to have enough DNA, but it's a conversation to be had because it may not require then a secondary biopsy for it. And this one was also positive for PIK3CA. These are some of my patients who have the PROS that involve the brain. And so this is a growth chart of the head circumference. What is expected would be between these lines. And so the patient had a larger head size. Whenever we see brain involvement, one of the takeaways is sometimes blood or a cheek swab may be enough. So I don't always, depending on the case, have to do a biopsy. And so I do take that into account when I'm taking the history, etc., for the tests. And this child who also had, you can see maybe on the MRI, this side looks a little maybe bigger than this one, so there was some overgrowth. This is a separate patient. They didn't have the bigger blood vessel malformations, but had a capillary one, and so we were able to get a skin punch biopsy from there. And the punch biopsies, most of the times I'm not doing them in clinic, although I can. They're usually the size of a pencil eraser, so they're pretty small. I don't stitch them, they close by, but we have to be careful on the areas that are biopsied. And so depending on the child or the adult and the case, I may be sending it to someone who does more procedures for that and not myself. And this is one of the exciting things. This is, I think, what's up and coming. I don't know if you guys have heard about cell-free DNA. And so some people may have. It's similar to what we're using now to test people who are pregnant where we test the blood from the mom, but are trying to see what the chromosomes of the baby and the sex of the baby looks like. So it turns out that all of our cells shed and die, and DNA is released to our blood, and we can measure it. It is expected that 10% of that DNA comes from the cells that line the blood vessels. Some of those may have the malformation. So some people in some studies have been able to take that blood work and test and find some of the variants from there. There's only one lab that you can send these to specifically, not as research, and they only test for some of those specific misspellings that I was showing you. It can require a little more blood than usual, so that's also something I have to think of when it's a little baby, because typically if we send 1 tube of blood, that's like 5 mLs, that's a teaspoon. But some of it may be closer to what a tablespoon would be of blood. And so that may spare people from a tissue biopsy. And we've been now collaborating with the group at CHOP. And this is one of my adult patients who we enrolled through this study, and she had a clinical diagnosis made by us of KT, and we found a PIK3CA variant. And so we're planning to start alpelisib. So I'm very excited about that too. So I think these are things that are up and coming and may become more available now that we have it. And I do not work alone. It's a full team of people, from basic science to my peers and our great genetic counselor, Jeanette, here, both from the children's hospital and the adult side.